afternoon, everyone. It's a pleasure to be here. Thank you, Kathy, for inviting me. I think this has been a fabulous conference so far. I think many of you know Boston Children's Hospital has a tremendous brand in the area of care delivery as well as innovation. And I'm going to speak to you today about the innovation aspect of our brand. And hopefully my Prezi will be coming up momentarily. There it is. Thank you. So I was sitting in my kitchen on a Saturday morning reading the newspaper, and I came across an article on creativity. And I learned you can get your creative juices flowing if you watch funny YouTube videos, or sit next to a big cardboard box, or surround yourself by the color blue. And I was enjoying the article, but I paused when I got to the point where they began to equate creativity with innovation. I thought, whoa. Creativity can lead to art and music and literature, but creativity is not innovation. So what is innovation? Well, as the Chief Innovation Officer at Boston Children's Hospital, this is a question I need to know the answer to. And today I'd like to talk to you about three things: what innovation is, the programs that we built at Boston Children's Hospital to foster innovation and give you some examples of our successes, and then finally talk about how you build a culture of innovation. So let's get started. What is innovation? Well, if you go to the dictionary, this is a definition you get. To innovate is to try out new ideas. And what I like about this definition is there's no guarantees of success when you're innovating. In fact, innovation is fraught with risk and uncertainty and even failure. And I also think the antonym really says a lot. If you're not innovating, you're dying. So I want to talk to you today specifically about clinical innovation. And if you look at the spectrum from research all the way through the business model and think about how research gets translated into the delivery of care, which needs to be coordinated with how we get paid, clinical innovation has a very broad span. So yes, it's new drugs and it's new devices, but it's also new communication tools for doctors, and it's new payment models like bundled care or the accountable care organizations that you may have heard about. Now, I'd like to also share with you another organizing framework for thinking about innovation, the innovation life cycle. I developed the innovation life cycle to help explain how innovation happens in a service industry, particularly in healthcare. And if you went to 3M and asked them for their innovation life cycle, it would be similar, but not exactly the same. And I want to spend a couple minutes talking with you about the 6 steps and the very important gap. So let's dive a little deeper. The first step in the innovation life cycle is initiation. And this is a very simple step, but it's important. And the initiation is where you identify your challenge, the problem, the area you want to innovate around, and you begin to envision some solutions. This could be done at the grassroots level, or it could be a big strategic problem that you're working out. But what's important at this phase is to identify the challenge and also to identify resources and scope out the project. Once you have the vision of where you'd like to innovate, the next step is ideation. And ideation is where you begin to come up with ideas. And sadly, people sometimes are confused and think that ideation is innovation. And it's not. It's part of the process. And there are a lot of ways to ideate. One very popular way is brainstorming. And who here has been involved in a brainstorming activity? Yeah, a lot of us. Very popular. I also encourage the innovators I'm working with, though, that they can find new ideas in other places, from our competitors or even outside of our industry. We can find solutions to the problems that we're facing. One of my favorite examples of a great idea for healthcare coming from someplace else was the project that one of our nurses did. Nurse Karen is a pediatric nurse in cardiac surgery, and she was concerned with the process of rewarming babies who had been cooled down for cardiac surgery. She felt that the blankets and the water baths being used weren't really rewarming the baby as quickly or as comfortably as possible. So she decided she wanted to innovate, and she came up with the idea of creating a new hat to help rewarm the babies. Because she figured, hey, you're losing 40% of your body heat through your head, why not, have a rewarming hat? So first idea she had was a knitted hat. She created some knitted hats, but those didn't work really well. They fell off the babies, and they got in the way of the surgeons. And she was thinking and looking around for some other idea. And it was actually while she was watching the marathon. And she saw the runners coming across the finish line, and they were being given Mylar blankets to warm up. And she had that aha moment. She said, Mylar, that's the material for me. It's lightweight, it's flexible, it reflects body heat. And so she came up with a very ingenious turban-style Mylar rewarming thermal hat. It lies flat on the operating table. It wraps around the baby and is secured with Velcro once it's needed. She went on to patent this idea, to do clinical trials, and we just recently were able to license this out to a manufacturer who will build these hats for us. So coming out of ideation, you move into the pilot stage. You harvest your best idea, and you build a functional prototype, or you mock up the idea. What's important in this phase is to have clear metrics, not moving goalposts. And if you're going to fail, this is where it's going to happen. But I believe that early, fast, cheap failure is actually a form of success. And one of my favorite examples of this is from my days at Kaiser Permanente when I was the Vice President of Innovation and Advanced Technology there. We wanted to innovate around our medication administration system. We were using these Pyxis machines that dispense the medication, and there was a lot of sort of jostling going on around the machines, and things just weren't working well. So we did some brainstorming, and we came up with the idea of taking our computer carts that the nurses and doctors use to chart electronically the medical record, and to add a medication drawer to the cart. And so we left the conference room, and we went into our innovation lab, and we mocked up this idea. And we quickly discovered in about 15 minutes that what was a great idea in the conference room was not going to fly on the hospital floor. Why? Well, those carts that the nurses were managing to push and pull throughout the day to do their computer charting were actually a little bit heavy to start with. And once we added a medication drawer and 25 pounds of the most popular medications, we created something they couldn't move. We built another boat anchor. So we scrapped that idea, went back to the drawing board, and came up with something totally different. But had we not mocked up that idea, had we not had our early failure, we would easily have spent millions of dollars outfitting our 39 hospitals with this new idea. So if you've had a successful pilot, in the ideal world, you are able to easily and rapidly translate it into broad operations. You tell people about your new idea, and they embrace it. But who lives in that ideal world? In the real world, people are not so eager to try out new ideas, and they're often afraid of change. And so I've coined the term for this adoption barrier that we see between pilot and operationalization. I call it the operationalization gap, or O gap. Now, which organizations suffer from the O gap? Well, it's much more of a problem in large organizations than small organizations, and it's also a bigger problem in organizations that have diffuse leadership, a lot of division. So if you have a real hierarchical command and control organization, like maybe the US military, you won't face as much of a problem with the O gap. Now, there's a lot of things you can do to try to close the O gap. You can re-engage leadership in the process. You can bring resources to bear in terms of education and change management. Sometimes the challenge in crossing the O gap is actually technical in nature, meaning you built a prototype which works great for 10 people but doesn't scale to an organization of 10,000. But probably more than anything, what's really valuable in closing the O gap is the recognition that it exists. And I advise my innovators that they're going to face the O gap. And I also counsel them to get the folks involved in operationalization into the innovation process earlier. Partner with them during ideation. Partner with them during pilot. That, more than anything, I believe, closes the O gap. So this is a great cartoon. What it really says is sometimes getting across the O gap can be even harder than commercializing something and getting a product out to market. So once you are across the O gap, you're into operationalization. This is when an organization realizes the full value of that new idea, of that innovation. But that's not the last step. There's an opportunity once the innovation is in the hands of the end users for optimization and local innovation. And then finally, no life cycle goes on forever. At some point, that great idea is no longer meeting your needs. Perhaps workflows change, there's a new, cheaper technology, and it's time to obsolete this innovation and begin the process again. And this is sort of a tricky phase. It's hard to know how to obsolete something that people have been using, and also to know when. And this is another great cartoon. It says, and this light here lets you know when the camera is obsolete. Wouldn't it be great if all of our devices came with that kind of light? Well, now that you're all innovation lifecycle experts, I want to talk to you a little bit about our work at Boston Children's Hospital. So Boston Children's Hospital is a 395-bed specialty pediatric hospital. We are the pediatric teaching facility for Harvard Medical School, and we have over 225 specialized clinics, everything from cardiac surgery to vascular anomalies, pain management, and autism. And in addition to delivering outstanding clinical care, we also do world-class research. We invest over $250 million every year in basic and clinical research. And if I can brag for a minute, we've been voted the #1 or #2 pediatric hospital in the nation by U.S. News & World Report for the last 3 years running. Now, Boston Children's Hospital has a very long and rich history of innovation, and I want to share a few highlights with you. Not long after we were founded, in 1891, we were the first hospital to be able to produce bacteria-free milk for the children in our hospital. 1947 was the year that one of our doctors, Dr. Sidney Farber, was the first person to be able to achieve leukemia remission. He put leukemia into remission, and Dr. Farber went on to found the Dana-Farber Cancer Institute. In 1952, Dr. John Enders and his team won the Nobel Prize for isolating the polio virus, and it was this work that laid the groundwork for Jonas Salk to go on to develop the polio vaccine to help eradicate that disease. In 1971, Dr. Judah Folkman and his team identified angiogenesis, the idea that cancer tumors require blood supply, and thereby opening an entire new treatment strategy for dealing with cancer. Now, I could go on all afternoon with examples of our innovation and our innovation history, but I know I'm what's standing between you and the break, so I want to fast forward to today and tell you about the Innovation Acceleration Program that I lead. Our mission is to enhance the innovation culture within Boston Children's with an aim of really accelerating clinical innovation. And we do this by taking a three-part approach to our mission. First of all, we want to initiate innovation. We want to identify unmet innovation opportunities and get work started. Second of all, we want to facilitate grassroots innovation. We want to help people test and develop new ideas. And then finally, we want to collaborate on strategic innovation initiatives at the institutional level. I'd like to give you some examples of our work in all three areas. So first of all, what are some examples of how we get innovation going? Well, we noticed, and you probably have too, an absolute fascination with mobile technologies, iPads, iPhones, iTouches, Android phones, and this hasn't been lost on the folks at Boston Children's. There's a real interest in leveraging these technologies and building mobile apps to help doctors and to help patients. And there was so much interest in this that it wasn't something that our team could resource directly. But what we could do to support this interest is to create the Mobile Apps Working Group. And this is a group that comes together in person and virtually to share what they're working on, to learn and to teach each other how to build mobile apps in the clinical environment. And we've had a number of terrific mobile apps built at Boston Children's. There's now an app for patients and their families that they can use in their room to see what's on the menu in the cafeteria basement downstairs. There's a mobile wayfinding app to help patients and their families navigate through the hospital and find their clinic or their destination. And a mobile app's even been built to help autistic children communicate better. We also run a monthly Innovators Forum where innovators can share the work that they're doing and get feedback from the community. We heard from a pediatric urologist who is working on an implantable artificial kidney. We also heard a while back from a cardiac fellow who is working on developing a light-activated glue to close the holes in babies' hearts. And maybe you saw this in the press last week. It was announced very broadly, very exciting work. And we even heard from our head of parking around his innovative work to get the valet cars back to the families more quickly. We also want to support the innovation community through our virtual collaboration tool. Our tool is called Spark, the social platform for accelerating resources and connections. And Spark can be used to blog, tweet, share documents, share videos. It's an internal social media site. It's a great way for innovators to find each other and find resources, as well as to enhance workflow. And we used Spark a while back for a crowdsourcing activity where we asked people to come forward with new ideas. In the course of the 5 days that the contest was open, we had 3,000 votes cast on 30 very novel ideas that were commented on and posted. We also held a fabulous event recently to help people bring forward new ideas in pediatric care called Hacking Pediatrics. And Hacking Pediatrics was a hackathon. It was an opportunity for people who had ideas for where innovation was needed in pediatric care to get together with developers, designers, software engineers to, over the course of one very intense weekend, come up with solutions. So the way it worked is people came and pitched their ideas, pitched the problems, and teams formed around them. And then these teams planned a solution, designed a solution, tested the solution, worked with patients, and then at the end of the weekend presented the idea out. We had 40 ideas pitched and 16 teams formed to come up with very interesting solutions. The winner, and there were many winners, but the one I'll share with you is one called RightBite, which is a new mobile app to help parents of kids who have food allergies quickly and easily find recipes for things that they can make in their home. It was a fabulous event, and we will definitely be having another hackathon in the near future. So I want to talk a little bit now about how we help facilitate grassroots innovation in our organization. We have a seed fund called the Innovestment Grant Fund that people can apply to when they need a small amount of money to get going and test out a new idea. And we have supported 33 new innovations through our investment grants so far. Some of them have been spectacular, and some of them have failed, but that's what you would expect. For innovators who have an idea that involves the creation of a new piece of clinical software, they don't apply to the Investment Grant Program. Rather, they apply to the Fast Track Innovation and Technology, or FIT award. And if they win a FIT award, they don't get money, but rather they get time with the developers on my team who will build out their proof of concept and support them while they test that prototype. And I want to share 3 examples of FIT projects that we've built with you. So the first one is Alice, and what we built was what you see on the right, the digital smartboard, to replace the grease board that you see on the left. And these grease boards were in very heavy use in the hospital. On every floor, this grease board showed which patient was in which room and who the doctor was and how to contact the doctor. And it wasn't a very good form of communication because it wasn't updated very often, and you had to be standing right in front of it to get any information. So we built the Alice smartboard, and what Alice does is in real time pull information in from 4 disparate clinical systems and display it digitally, but not just on the monitor in that one unit, but anywhere that you can access the electronic medical record at Boston Children's Hospital, you can see Alice. And what this means is a doctor 4 flights down can actually check if a patient is in their room before making the trip up to see them. We worked very closely during the pilot with the operations folks, and I'm pleased to tell you we got across the OGAP in no time, and Alice is now broadly deployed across the organization, and I would say we're in the optimization phase at this point. The second example I want to share with you is called BEAPPER. So we're an academic medical center with a very busy emergency department. We have over 400 staff that rotate in to take care of kids. And all staff don't know each other, and it's a very busy place. And so one of our innovators, Dr. Deb, came and applied for a FIT award because she had a vision for how to create a better communication platform for the emergency department. And now we'll hopefully hear the video of BEAPPER.
We have a very big and busy emergency department. We have over 50 bed spaces, over 100 nurses, and over 100 doctors full-time, and over 200 trainees. We see about 150 patients a day, 55,000 patients a year. We work very hard in this emergency department to work as a team, and when we take care of patients, there's a lot of communication that we want to happen. For example, we need to know when the patient is in a room, when their status changes, when results are back, and not knowing when that information is available prolongs the amount of time that a patient is here. I thought that perhaps we could include technology in our communication by developing and using a Twitter-like application so that we could communicate with each other more effectively and more efficiently. BEAPPER gives us demographic information about our patients, their chief complaints, so why they're here, and where in the emergency department they're located, as well as which providers are on the team taking care of those patients. BEAPPER also gives us a way to send what I call beeps, communications to those providers. The software lets the hospital systems communicate with us. It can let you know when orders have been placed. It will let you know when results are back, when a bed is ready for a patient who's being admitted to the hospital. If using BEAPPER, we could save even just 5 minutes per patient. We could see an additional nearly 1,400 patients a year without any additional physical or human resources in this ED. We also think that BEAPPER can help with patient safety, and that is one of our highest priorities. BEAPPER can alert us to remember to do timeouts before we do procedures, to collect consent forms, for providers to communicate with each other when patient status has changed. What BEAPPER can offer is better communication between providers. And if providers all know what's happening with their patient, it translates to better, more efficient care.
Our BEAPPER pilot of 3 months demonstrated that we could get lab results back to our doctors 28% faster. That meant they could do their jobs more quickly, and hopefully the patients could get through the emergency department more quickly also. And I want to share one final example of our FIT projects. It's a mobile app called My Passport that was developed by the FIT team to help patients navigate their stay with Boston Children's Hospital, because it can often be overwhelming and confusing and hard to get information when your child is hospitalized. So there's 4 features to My Passport. The first is that patients and their families can actually see the lab results as they're coming back. And we created a very nice user interface that we think is a little clearer and easier to digest for the families. Second of all, through My Passport, families can see who's on the patient's care team. They see a picture of everyone who comes to see their child, as well as their name and their role. And this can really be a huge help, because often there's a veritable parade of caregivers coming through any patient's room. Third, through My Passport, the family can also access the care plan, so they can know what's being planned for their child and what needs to happen before the child can be discharged. And then finally, My Passport also offers the opportunity for asynchronous communication. So if a family has a question when there's no caregiver in the room, they can send a message through My Passport and get an answer back. And now I want to talk a little bit about what we're doing to collaborate at the institutional level. We have been instrumental in starting the telehealth program and strategy for Boston Children's Hospital. So telehealth is the remote delivery of care where you leverage computers, cell phones to really deliver care to the patient. And it's fundamentally a paradigm shift in how care is delivered, because now instead of the patient coming to the doctor, the care is going to the patient wherever they are, at home, at school, or if it was an adult at work. And we have been looking at how we can use this mechanism to deliver direct patient care, how we can facilitate virtual physician-to-physician collaboration, and teleeducation. So now you're probably wondering who does all this work and supports all this. Well, this is my team, the Innovation Acceleration Program. Now, we are not a group of superstar innovators. We are really about facilitating and supporting others all around the organization in innovating. I work closely with Dr. Pedro Del Nido. He's the chief of cardiac surgery and himself an amazing innovator. And the rest of the team comes from a variety of backgrounds. And I like to think of my team as the Dream Sherpas of Boston Children's Hospital. So now I'd like to talk to you about the third topic I mentioned, which is how to build an innovation culture within an organization. And I think there are 4 key elements. So I created this 4R mnemonic, and I'll share each of them with you now. So the first R is recognizing the process. And this is really about understanding the innovation life cycle, which is an incredibly useful organizing paradigm for understanding and facilitating innovation. Understanding the innovation life cycle can help an organization think about where to place its resources to support innovation, and can help innovators know what to expect, particularly when it comes to the OGAP. The second R is around resourcing innovators. So innovators usually need time, sometimes money, and often advice. And I've shared with you a little bit about some of the programs that Boston Children's Hospital has built. We've been focusing primarily on supporting innovators in the ideation and pilot phase with a little bit of support around the OGAP. Now the third R is risk-taking. And we've talked about the fact that innovation is fundamentally risky. And with risk comes failure. But how an organization deals with failure is really key in setting up a culture of innovation. It's important when there's a failure to recognize that as a learning opportunity. And it's important that an organization not punish an innovator when an idea doesn't pan out. What organizations need to do in order to create a culture of innovation is strive to create a safe environment where innovation is encouraged, risk is accepted, and failure is recognized as a learning opportunity. And finally, the fourth R, reward and appreciate. So innovation is fundamentally hard. It doesn't always work out. It can be very frustrating to be an innovator. I was speaking to one of our innovators who's developing injectable microbubbles to oxygenate the blood, and he said he was on the 300th iteration of that project. So what's really important for an organization to do is to recognize their innovators and to support them and to reward them for being so diligent and to be trying to come up with new ideas. And so the way we did this recently was we held an innovation day. And what we did was we created a platform, an opportunity for our innovators to come and share what they've been working on. Innovation Day was hosted by our president and CEO. We had a packed auditorium of 200 people listening to the presentations, as well as about another 200 people online. And it really was a chance for the innovators to shine, to share what they were working on, and to be recognized for their hard work. And they got a lot of internal recognition, as you can imagine, and they were very inspiring to others, and a lot of external recognition in the press and on the blogosphere. So in conclusion, I would say that innovation is one of the most talked about topics in business and healthcare today. But innovation doesn't happen by chance. It's governed by a 6-step innovation life cycle and the elusive OGAP. And I've shared with you some examples of how we built innovation programs at Boston Children's Hospital and some of the outcomes from those programs. So if you're thinking about innovation, you don't need to watch funny YouTube videos or paint your room blue. What you need to do is embrace risk, provide some resources, reward and recognize the innovators, and understand the innovation life cycle. So I want to thank you for your time this afternoon. I would love to take questions, but I know we don't have time. But I would invite you to email me or reach me on Twitter. I tweet frequently about innovation, and I look forward to continuing the conversation. Thank you very much.